morning. This is the Forum-Pat Sacco, and we are back again this week. We're into our phase one. How many days? 5 days now? 4 days? Started
4 days,
Monday.
I think about that's
Started
all right.
Monday, right?
Yep.
And understand that the 3 counties that were excluded from phase one, the governor is now dialoguing about bringing them on. I'm sure there was a hue and a cry saying, how come they get it and we don't? It's like a little kid. You gave me candy. My brother got the candy. I didn't get it. Dade County, Palm Beach County, and Broward County.
Yeah.
That's where the highest concentration of the virus and deaths were in the state.
Yeah.
And I think that's a great idea. When you find there's a problem and a concentration, you delay it or you shut it down until it rectifies itself.
Yeah, you got to act appropriately and individualize, restrictions, treatments, just like, we do in medicine,
Right.
you
and
want
you
to
cut off your leg to spite your face saying,
Yep.
Yeah,
New York restrictions should be different than Stewart, Florida.
It's like the old adage, when you're in a lifeboat and it'll hold 10 people and you have 11. You have a choice. You have to lessen the weight. Do you cut one arm off of everybody or do you throw one person overboard? And in this case, do you shut down the whole county, the whole state, or do you focus on the other problems? Anyway, I'm chatting with my guests. I haven't even introduced them or anything. This is Joe. Where's Becky?
Yep, you got it. You said it exactly right. I tell people the easiest way to say it is, where is Becky? Where's Becky? It's a tough Polish last name.
Right.
Yep.
Some, again, I can relate because there's some Italian real rough names. And they don't even pronounce their vowels and stuff. And they glide over things. If it's Battaglia, it's not Battaglia, it's Battaglia. In fact, they even leave out a sound. But that's typical for.
Oh yes.
For both our races.
Oh yeah. Used to people butchering our last name, so there's nothing new there.
Now, did you live in a Polish?
I love that people try.
Did you live in a Polish neighborhood?
So my family's from right outside of a small Polish community in Detroit called Hamtramck, Michigan. Yep. So yeah, it's a bit of a different community now, but
Detroit,
I still
Elas.
love going back for the Polish festivals.
Elas is a Greek restaurant down there where they have the those tubes of heat outside when you're waiting in line to keep you from getting cold.
Yep.
Very famous restaurant there. I always associate restaurants with where I go.
Oh yeah. Yeah. So, but no, I've been down here in Florida now about 10 years. I've been with Dr. Power's orthopedic group for, I think, 8 years.
Really?
And then I was in various parts of Florida a couple of years prior, with various stages of my medical training, for family medicine and sports medicine in Gainesville, Florida, and then the non-surgical orthopedic part in Tampa. So I've been all around the state, but I like it here. It's nice and quiet.
Treasure Coast
calm.
is unique.
They do it well here. Yeah.
In fact, I knew I liked Joe when we got to talking last time. I found out when he was a young boy, up to the age of 12, I believe. Did you move?
Yep. Oh, yeah. I moved all around. Oh, yeah. New York, Michigan, Ohio.
He lived in a little town called Fairport, New York.
Yep.
Which is about 2 or 3 miles where I grew up. How does that happen?
Yep. Small world.
Oh, my God.
I love these coincidences, these connections. Yeah.
It took me a little longer to leave than it did to you.
Yep. Yeah.
But there was a stark change from going from Fairport to where you went.
Oh, yes. Yep. For the better. New York, I will always remember fondly, but you remember those severe ice storms and blizzards. Those were a bit tougher times.
One winter.
I miss the leaves changing colors,
Me
though.
too.
I do.
2 weeks in the fall. One time, it was March. I was arguing with a friend. I said, geez, we had 10 snowstorms. And he said, no, we only had 3. I said, what were the other 7? He said, lake effect. Yeah. I said, well, tell the difference in my snowblower. Still brought 2 or 3 feet of snow. I don't care what you label it.
Yep. We don't get that down here. Yeah, thank God.
And we bought a repossessed old 100-year-old home, 3-story gorgeous thing with a gas furnace. And I remember my bills during the wintertime were somewhere between $600 and $700 a month. And then finally I bought a wood burning stove and I put it in a little fireplace and we'd stoke it up at night when we got home and then kept the the French doors closed, and as soon as we went to bed, we opened the doors, and the heat went upstairs for the evening.
Mm.
You have to improvise sometimes.
Oh yeah, you got to get creative with life, with anything. Yeah, just like with my patients, I'm telling them how to get creative with various things. You can't run anymore. Okay, well, here's how we're going to get creative.
Mhm.
Or I got to do this. Well, all right, well, let's brainstorm. Let's get creative to make this work for you and your life. It's part of the spice of life, the fun.
Right, and people with less than perfect bodies, and you deal with them.
Oh yeah.
Get depressed because I can't run anymore. I can't do these things. I used to be able to put my arms on a refrigerator and pick it up and move it. Now all I can do is open the door. Right? So I can accommodate.
But you count your blessings. Yeah, you still got a good arm to open the door.
Yeah.
Yep, we got these resources. We got these fancy machines and whatnot. Like a lot of people who have bad hand arthritis, they can't open a lot of objects. Well, you go online and search, and you'll see a lot of different type of grippers that work really well, where you apply minimal grip strength, and you can open something like a pickle jar, or like a tight cap on top of like a soda pop bottle. Or something like a lot of people have a tough time because of their hips or their back getting to their socks or their shoes. You see these, the different infomercials about those kind of extenders that'll help you to put on your shoe or your sock. Yeah, there's all kinds of creative things out there to help us work around these things that are a normal part of wear and tear and living as long as we live.
Well, I remember I was working with a Parkinson patient trying to get better volume, and he was all upset because he couldn't eat. He had to have somebody feed him. He couldn't. The spoon was shaking. I said, there are weighted spoons. Spoons with weights in them. They use for cerebral palsy children. He got a spoon he could eat because it was heavy enough that he didn't get that tremor to get the food to his mouth.
Yeah.
And that's a big psychological thing to a man, particularly. He's not dependent on someone to feed him like a baby. That whole mental thing.
It does, yeah. The mental thing we were talking about even before the show, and then how that affects your entire rest of the body. I mean, think about how it affects your stress levels, which affects your heart, your gut, and then just how it affects your mind and your whole way of living. Everything is affected by these small little things.
When you go on their website, you'll find that there are national links. There are about 200 of them, the different diseases I deal with, and there's a chunk on Parkinson's. And I gave a lecture down at the library in Hope Sound. And afterwards, the lady who set it up came to me and said, would you talk to my husband? He has Parkinson. He won't listen to me. He won't do anything. He won't talk to anybody. So I sat down and I said, what the hell is the matter with you? I said, don't you have needs? Yeah, but I said, oh, wait, here's this website. This is a Parkinson chat room. I said, you operate a computer? Oh, yeah. I said, fine, go on there. Say, okay, here's the problem I'm having. You get 4 or 5 people will tell you their solutions.
People are very active on these forums and very helpful. And a lot of times you search and maybe someone has said something like that before, and you find the answer without you even having to type it in and wait.
It's called It Takes a Village.
Yeah.
Okay.
Yeah, right.
I want a group of people and if I don't call them or get online, after a while, they'll email me and say, how come you haven't called us? How come you didn't bring a problem? Yeah. He said, oh, I can do that.
Yeah.
Duh.
It's funny too. There's almost no question out there that hasn't been asked before. You type it in Google, someone has asked that question before, and you'll get your answer pretty quickly.
And I mean to go through my medical things because it would take the whole hour. But one instance, I had open heart surgery, and I was down in intensive care, and there was a guy next to me, and he was going, "Oh, my life is over. Oh, I won't be able." I wanted to get up and slap him.
Yeah.
Because when I woke up, I was laughing, and they said, "Why are you laughing?" I said, "I'm alive." Because I didn't think I was going to make
positive thinking. I agree.
So, in fact, I let the hospital know if there was ever a patient like that, I'd come and talk to them, show my scar, and say, "Hey, I'm alive, and this is what I've done. And this is what you can do."
People need to hear it from others who have been through the same thing, also, because that's one of the first things you hear is, "Well, you don't know, you haven't been through this."
Right.
But when you have, they don't have that that defense to throw back at you, and then you can really make progress.
And the other alternative is the person who has their training to deal with you, like you.
Yep.
Oh, my knee hurts. Oh, don't walk so much. Wait a minute.
Yep. Oh, yeah.
That's not the end
And I like to
discussion.
think some
That's
of
the
my
beginning.
various orthopedic injuries has been maybe God's or someone's master plan in order to help me empathize with my patients. I
Mhm.
broke my arm back in the day so that I could relate to, the 8-year-old now or the 50-year-old with the broken arm, or, I tore my meniscus in my knee so that I can better empathize and instruct, from a firsthand perspective, what you're going through and how you go through this. I mean, yeah, I'm counting my blessings there, these various injuries I've had.
Yeah, right.
Yeah,
Okay.
it's one way, it's one perspective. Yeah, sure.
Education, training.
Yep. So I'm from the Midwest, and so I did undergraduate with the Jesuits in Omaha, Nebraska.
Ah.
Yep. Creighton University. Then after that, my home state, Kansas, is where I did medical school. So University of Kansas is where I got my MD. But I've always liked to say that I'm a Floridian at heart. And so once I had the opportunity after that, I moved down to Florida. And I was always interested in general medicine and specifically sports medicine. So that's what drove me to the University of Florida, which is just great with well-rounded medical care, but is also known for their sports teams. And so orthopedics and sports medicine. And then after that, I further specialized in non-surgical orthopedics, or a lot of injections. And I did that training in Tampa. And then after that, like I said, I've been in this area about 8 years now with Dr. Powers and Florida orthopedic specialists. And for those of us who don't know, we have 2 offices in the area, one in Port St. Lucie on Highway 1 and Walton Road. And the other office is in Stewart off of Indian Street and Highway 1. And you can find us, on our website.
Right near the corner.
Yep. And if you want to give us a call, our number is 772-335-0305. Yeah. So
Plus,
that's my background, and I'm here.
I love the way you're operating under this crisis.
Yeah. Yeah. Because a lot of people were asking.
You don't walk in the door. You
Mhm.
let them know you're here, and you go back and sit in your car.
Yep.
And when they're ready for you, they call you, because I had to see Dr. Wisbecki for my back,
Yep.
I guess, and my attitude. Well, actually, we were setting up this program also. And they called me. I went to the door. The door was open, and I went to sit down, and the girl opened the door and said, "Follow me." There was nobody in the waiting area.
Yep.
Slam bam right in. I love that idea.
Yeah, the first question that we get asked is, are you open right now? And yes, it's very important that a lot of medical offices stay open, because you don't want people in the ER. And so we don't want people in the ER with fractures, sprains that don't need to be. And so, yes, it's important that all the other medical offices are open to help unload that. So we've been open this whole time, and we will be. We have some modified hours and some modified policies, like you're saying. We don't have people sitting in our waiting room. They come in, they kind of fill out their form, they give us the telephone number, and then we call them from their car on their cell phone, if they have a cell phone. If they don't, then you let us know where we're parked, and someone will come out and kind of wave at your car. And then we bring you right into that exam room that has been disinfected, and everyone's wearing their masks. And so we're taking all the precautions that we can. Of course, there's always some risk with just getting out there, but this risk is a little bit of living. And so a little bit of risk, but we do everything possible to minimize that risk and that exposure.
Love that. It was really a big plus to me in how you dealt with your patients.
Yeah.
Took some thought. Took some thought.
Yep. And we're doing everything possible. Yes, some patients would like to see us in complete, almost like hazmat suits, but of course that's just not feasible. But just disinfecting everything, and constantly washing our hands, wearing the masks when appropriate, wearing gloves. One thing that's funny, that some people want us all wearing gloves, but right now it's actually, I would be violating health code if I was wearing gloves with every single patient. Right. Because I would be depleting some of that equipment that is better used in other parts of the country. And so whenever I put on gloves, I have to actually document in the patient's chart why I'm putting on gloves. Because there has to be a medical necessity for that right now.
Well, I used to see in some nursing homes, an aide would put on gloves for the day. Never changed them.
Yep. Right.
And just taking the infection from one patient, passing over to but she didn't get the infection.
Yep.
Or he. That was not right.
Yeah. And people, that's one thing that not everyone is as aware of as they should be, is with this personal protective equipment. Well, you just can't, you need to be very careful with it. If you're wearing gloves all day long, well, then you're likely just moving the infection from one spot to another. Exactly. Or touching your face or your mask or whatever with the glove. Well, then it's not doing any good. You need to be very careful what you're touching and when you're changing it and whatnot.
Well, I don't.
I see a lot of people messing with their masks too. If let's say that you're exposed to that virus and that virus is on the mask. Well, if you're constantly messing with your mask,
It's
then
on
you're
your
just going to
hand and
move things
it's- yeah,
around.
right,
Yep.
right.
And so there's too many of us who are messing with the mask. And if you're going to mess with the mask, you need to mess with it, around the straps, not around where you breathe from and where the filtration is.
Yeah. I don't wear gloves. I rarely, if ever, had worn gloves. I did an internship at the VA hospital in Louisville, Kentucky, under a speech pathologist. It was a teaching hospital. It was fabulous. It was fabulous. But there were all kinds of precautions there.
Mhm.
And I never, with the gloves, I didn't realize you don't just take gloves off and take them off, like pull them. You got to take your finger and stick your finger inside,
Yep.
push it so it's reversed.
Mm-hmm.
And you touch the inside reversed part, not the outside part. People need to be oriented how to take gloves off.
Yep. Yeah, if you do these things improperly, well, then they're not doing their purpose.
Exactly.
Actually, so this, that's it's a good topic. Along those same topic lines is how everything else in orthopedics is different because of the coronavirus and what's going on with the epidemic. For a lot of orthopedic conditions, people have been recommended anti-inflammatories before, and then they're hearing some things on the TV about, should I not be taking anti-inflammatories because of coronavirus, or, maybe cortisone or prednisone, those injections or those pills, and they may hear some information out there. And those are the two ones that I get asked about a lot these days, because there were some reports early on that there was a correlation between people who had coronavirus and if they were also on NSAIDs or anti-inflammatory pills, and that they had a worse outcome. And so because of that, the news media really ran with it because, hey, it's a story, it gets clicks and it gets attention and it sells. But when you actually look at that study, it was a very small number of people and the association was not anything statistically significant. And so a lot of people come in and they're very afraid of taking something like ibuprofen or Aleve, these NSAIDs for their pain because, they heard about that report, they heard about it on TV. But I would say all doctors I have talked to would say, do not change how you are taking anti-inflammatory pills based on what you heard on TV about that's association with coronavirus. If I was at high risk, if I was in New York and maybe I was over the age of 65 and I had bad knee arthritis, I would still be taking my ibuprofen. It would not affect my behavior at all. The same thing goes with steroids. People try and extrapolate, well, anti-inflammatories have that effect. Well, cortisone or prednisone, that has an effect on your immune system. And so therefore it could possibly affect how your body responds to a coronavirus infection if you did have the coronavirus. But all that is in theory. And actually, when people have the coronavirus, what they get is a respiratory distress syndrome. And very, very often, if someone has respiratory distress, we put them on steroids, we put them on cortisone because you need to kind of blunt the body's inflammatory response. And a lot of the times what's happening with these infections is that we get over inflammation and that causes a lot of problems in our body. So cortisone, prednisone, if your doctor's talking about putting you on that or you're on it, I would not change your behavior or not do what the doctor says because you're worried about that anti-inflammatory effect and possible association with coronavirus infection.
Well, you have to really be careful. I've taken enough statistics to know that you be very careful about looking at studies. Is there a large enough sample?
Yes.
Are we doing all left-handed people under 3 feet in Martin County? Is not going to be a correlation coefficient. It's going to be a Spearman Rowe. That compensates for the largeness. Here's a little study. This is a trend, and it is not an ultimate proof.
Yep. And people,
trend.
there's a saying that I was trying to find the exact quote with it, but it's something like statistics are a wonderful thing. You can make them say whatever you want. And it's really funny. And one of my favorite examples kind of goes back to anti-inflammatory pills too, because they get such a bad rap out there, in the news and in social media, whatever, just because it's something that people click on. But a lot of people say, well, there's that side effect that if you're on anti-inflammatory pills, well, Fox News told me that it's more likely that I'm going to have a heart attack. Right. Well, when you actually look at the big studies, what you find is if you're a person over the age of 50, your odds of having a heart attack, including everyone, is 1 in 1,000. Now, if you take everyone over the age of 50 who is also on an anti-inflammatory pill, your chances of having a heart attack is 2 in 1,000.
Oh
So
my
you could
God,
say,
it doubled.
yes, you could say, right. One way of looking at the statistic is saying it doubles your risk of having a
Twice
heart
as-
attack, right? Because it takes you from 1 in 1,000 to 2 in 1,000. Or you could say it increases your risk, from right, from 1 in 1,000 to 2 in 1,000, which I find much more telling and useful.
There's a story about statistics. This researcher was studying spiders, and he wanted to know about their movement and stuff. So he put a spider on the table and banged his hand on the table, and the spider jumped about 1.5 feet. So he plucked the leg from the spider, put him down, he hit it again, less than that. Plucked the second leg, less than that. Plucked the third leg, less than that. Now the spider was down to one leg. So he plucked the leg and put the spider down. The spider didn't move. So in his notes, he wrote, when you remove all the legs from the spider, they become deaf.
Cute.
And sometimes that's what happens with the interpretation of statistics. I like large numbers. I like to be told, a sample of 5,000 or 10,000 or whatever. And what they're doing right now is trying some of these medications. And they've started out with a small N. They're up to 3,000 to 15,000 or more until they get to a point where they say, now this is data that is reproducible.
Yep.
Okay. It's reproducible and it's valid. We need both of those things.
Yep. And
are you measuring what you think you're going to measure? And how often can you get the same results?
In research statistics, it's a very difficult area. Doctors are fooled all the time by studies, because we're constantly trying to absorb information and we have various biases. One is confirmation bias. If you already believe something and you read a headline that says what you already believe, well, then you're not going to investigate that further. Versus if you see something that's contrary to what you believe, well, then you are really going to dig into that report. And so our confirmation bias is one of them. There's another old saying that I like is that when faced with the decision between changing one's mind and proving there is no need to do so, nearly everyone gets busy on the proof.
Yep.
People like being right. Yeah.
What about cortisone injections?
Cortisone. So cortisone injections, a lot of bad information out there on cortisone. And the reason I believe that is there's a lot of these myths and bad information is because people are taking known side effects of cortisone pills or prednisone pills and then applying that to cortisone injections, which is a completely different things. So cortisone injections do not give you osteoporosis. It does not wear out your bones. It does not degrade the cartilage, the ligaments, the tendons, the muscle, the joint. It doesn't do any of that. Researchers have been trying to prove for years that it does that, but they've been unable to do so. Now, as long as you're doing everything in moderation. Now, if you're overdosing on cortisone injections, then it can do those things. But no doctor, no responsible doctor these days is doing that. And what we often say for a particular joint, take the knee joint, for example, we do a lot of cortisone injections in the knee. As long as you're not doing more than 4 injections in that particular knee in a year, then you're not overdosing on it. Some people will say 3, some people will say 4. But everything in moderation. And so cortisone injections are great. Yes, they don't fix the underlying problem. And that's the other thing that I hear from people, some pushback about cortisone is, well, it's a Band-Aid. Yes, it's a Band-Aid, but if it's a Band-Aid that improves your quality of life, well, then that's a pretty great Band-Aid. If that's a Band-Aid that allows you to not limp and to move normally and without pain for 3 months, 6 months, well, that's a pretty good Band-Aid. I'm happy with that. Because what's the alternate way of approaching that? Doing nothing and suffering, or doing surgery,
right?
Yeah, or doing something else that's more expensive. So people will ask about PRP or stem cell injections for their knee, and that's a lot of injections that I do too. Now, those ones I like to use very appropriately because insurance companies don't cover those ones. And yes, they could give you a better Band-Aid than something like the cortisone. But if there is a cheaper, more cost-effective Band-Aid that works just as well, I'd rather use that one. So
why don't they cover it?
Because there's not enough research yet. There's not powerful enough research. And they get to define that. So they have some fancy loopholes in how they decide what is and what isn't covered.
It's like medical marijuana.
Yep.
That is a treatment. And many, many people find relief. but it's not covered under insurance.
Yep. So one of our biggest problems is for years, many people have been getting gel shots, the rooster comb injections in their knees for knee arthritis. I do a lot of these
What was that?
injections. Some people call them the gel shots. It's like this very thick gel that we inject into the knee in order to give you some shock absorber in the knee.
Okay.
I call them gel injections. Most people know them as like a rooster comb injection because previously this protein within the gel was harvested from the rooster's comb.
Oh,
It contains cartilage proteins. And so we inject that into a concentrated way into the knee to give you cushion. And that's been paid for years. But then Blue Cross Blue Shield, they found a loophole where they were allowed to say that it wasn't a permanent enough treatment. And so then Blue Cross Blue Shield has been the only company that's been able to deny this to a lot of people who are having success.
and they're rather large.
Yep. And so, and unfortunately they have the power, and I do my best to convince them, but they make the rules. And so it's unfortunate, but they are very good at avoiding paying for things, much better than I am at fighting for it if they're too big.
Well, yeah,
But luckily the majority of insurance companies and plans cover this, but Blue Cross Blue Shield has been especially problematic for me and my patients for certain injections. And you'd think Blue Cross Blue Shield are so well known. How could they be a problem one? No, they are.
and it's going to be a regular thing if it's a proper treatment for a patient. He's going to get a bunch of these over the course of time, and it's worth it for them to sell more of this material.
Yep.
And yet, and sometime, well, I don't know how it happens, but I've heard that a lot of people make decisions from pharmaceutical companies are not trained physicians.
Nope. And the people who are making the decisions from these insurance companies too, they may have a high school degree, maybe,
Right.
and they're the ones who are approving or denying these treatments that doctors are recommending and that patients need. So it's unfortunate that's our system.
I have great respect for secretaries, but I'm not sure they should be talking to a doctor to let the doctor know whether this is going to be covered in his medical judgment or not.
Yep. And so there's
That's not a good thing.
Yeah. So anyways, I try not get too deep into that topic because, it's one of those things that I can't change. And so it's just frustrating. And so I just do the best I can to operate within the system and the loopholes that I know in order to help my patients. But yeah, it is the sad reality that our medical system is broken, that our insurance companies that we have to fight with and don't seem to be advocate for the patients. But, doctors, we just do our best to do what we can for you.
I'm not an alcoholic, but I live my life with the alcoholic's creed.
You live your life with
God, give me the strength to change the things that I can change. With this change and courage, to change the things that I can change, the ability to accept the things I can't change, and the wisdom to know the difference.
Yep.
If something's out there I can't do anything about it, I'm not going to get all upset.
Yep.
But if there's a thing that I can do to make a change, I will give it my all.
Yep.
But you have to be able to draw the line.
Yep.
Some people won't ever accept anything.
Yep. Yeah. It's
all the
true.
demand for change.
And that's a common thing that I'm talking about with my patients is okay, we use this saying a lot, it is what it is. So that is what it is. Now, here are some options to do something about it. We don't want to just dwell on something that we can't do anything about. Sometimes people come in and they just want to know a diagnosis. They want to know what it is. And then they can at least go forward. A lot of people, they'll sit in their bed wondering if their chronic knee pain is related to cancer. Well, come in and find out, that it's not related to cancer, at least. That at least gives you some mental rest going forward and knowing what some options are. And so a lot of the times it's giving people some mental rest, giving them a diagnosis, and then letting them know what they can do if they want to do something about it. And, a lot of our aches and pains, we can't do a lot for, but those ones that really bother you, there are options out there and a lot of non-surgical options. So I'm the non-surgical specialist. And what the numbers say is that 90% of all orthopedic problems can be improved with non-surgical measures.
Right.
And me, I'm the last person to recommend the surgery because I'm not the surgeon. I work with the surgeons. And so when something needs the surgery, well, it means something when it's coming from me, the non-surgeon, and I help to get you with that surgeon, whether it's for the back, the shoulder, the hand, whatever. But there is options out there. And if your arthritis pain or your chronic hand pain or knee pain is bothering you that much, well, get something done about it. It's funny. I'll be in the gym, listening to people talk and, that stuff catches my ear. And, I heard this one guy just saying for many, many years, it's my knee, it's arthritis, but what can they do about it? They can't do anything. You can't cure arthritis. And I don't like to, butt into conversations, but eventually he got my name and came in, and he found out, well, there is quite a bit that you can do for arthritis to make it more livable than it had been for him.
Mm-hmm. And that's the whole point.
Yep. Quality of life. I always come back to quality of life. If something is impacting your quality of life, well, then let's do something about it. If it's not, well, then maybe we just give a name to it. We find out and give you a diagnosis so you know comfortably what it is. But quality of life is a big thing for me and for my patients.
We're going to take a little break, and we'll be right back. All right, and we're back again from our little commercials. And I'm here with Dr. Joseph Borsbecki.
Yep, you got it. Saying it right.
Right on my tongue.
Yep, and I'm here local with Florida orthopedic specialists. Again, if you want to come and see me in the office, number is 772-335. 335-4770. And we got the office in Port St. Lucie on Highway 1 and Walton Road, and then the other office in Stewart on Highway 1 and Indian Street.
But before we leave, we got to plug Dr. Wierzbicki also.
Yeah, I got to remind people who's this great guy that they're talking to.
No, the other
here.
one. The other one that you go home to.
Oh, yes. Yeah. And my wife, the other Dr. Wierzbicki. So the link on your website will be to drw.org. Doctor spelled out, and w.org. And the other Dr. W is my wife, who is a general and cosmetic dentist. She's very good at what she does. You can see it by her teeth and by her patients' teeth. So she is a general and cosmetic dentist in Fort Pierce, and she is fantastic.
Does she do the insert?
Oh yeah,
drill in the bone and.
Yep, the implants. I hear all about implants and root canals and what are the other things? Bridges and veneers.
Yeah,
all this stuff that she does.
Doesn't that hurt over time?
She's got a very gentle touch and very good with the injection to numb up.
No,
that
I'm talking
area.
about the implants.
It shouldn't. No. From what I understand from her. Yeah, I'm not the expert on this dental stuff, but yeah, from what I hear from her, I get a lot of secondhand information. Yeah. So yeah, if you're looking for either me, Dr. Wierzbicki, or my wife, Dr. Wierzbicki, you can find us on the website, drw.org.
What's her first name?
Her name is Bethany.
Bethany.
Bethany
Okay.
Wierzbicki. It's got a ring to it. Yeah, she wasn't too happy about changing from a more normal sounding last name to Wierzbicki, but so I try and positively reassure her. It's got a ring to it.
That's a sacrifice she had to make.
Yep.
You know?
Yep. Yep. So, I'm the general orthopedic guy, the non-surgical orthopedics injection guy. And I was trained and board certified in family medicine also. And so I have a passion and curiosity for general medicine. So I talk a lot about that with my patients too.
And I like the path that you took, because even though you had this thought about sports medicine, et cetera, you didn't just go into phys ed and sports medicine.
Yep.
To,
sure. I mean,
to run out in the football field and look at the knee. Yep. There's more to that than that.
Yeah, there's various routes that someone could take to become, an orthopedist. Someone could finish medical school and then go to a surgery program where you're focusing on surgery constantly and then specializing in a certain part of orthopedics. Or you could go to just a physiatry type program, physical medicine and rehabilitation, where you're just focused on all the muscles and whatnot and the nerves. Or you can take the path that I did, which is to do general medicine first with a focus on orthopedics all along, and then get further fellowship training in orthopedics. And orthopedics, it's not just the muscle, the tendon, the bone. It's well-rounded. The brain has an effect. People's hearts come into play, their immune system, their GI system. And so the well-rounded medical knowledge, I think, has really benefited me in my practice. To be able to talk about a person's gout history and the medicine that they're on there, or their blood pressure medicine, or their kidney disease, and how we best treat their orthopedic problem considering their medical history.
Well, again, I, for one, would look for a person like you to deal with my problem, because you have this broad approach.
Yep. And I'm the diagnosis guy. People come in, they want to find out, do they have bad knees and they may need a knee surgery and a consult with a knee surgeon? Do they just need a cortisone shot? Do they need an MRI to make a further diagnosis? Do we just need some physical therapy or a brace? I'm doing all those things. Yep. Except for the surgery. Yep. I'll let all the surgeons focus on, the nuts and the plates and the plates and the screws. I don't have to focus on that stuff. I focus on the medicines and the injection and everything else.
I think we talked about MRIs with pacemakers.
Yep.
I'm due for a new one. I'm due for a new one. I'm getting to the point where they're going to say this is done, but there's a 3-month window, and I'm being tested every month now.
So MRI actually, it's just MRI scanners. They use magnets in order to get the picture, and they're great for soft tissues, tendons, ligaments, meniscus tears, nerves. MRIs are especially useful for. But people who have metal in their body that would react with the MRI scanner, or people who have a mechanical device that could be affected by the magnet, or the wires, then you can't have an MRI scanner. Now, interestingly, I don't know how long ago, but it seems like for many years, pacemakers and certain cardiac defibrillators have been MRI compatible. But because there is that, in theory, risk of things being altered by the MRI scanner, a lot of MRI places won't give someone an MRI if they have a device like that, because they're still afraid of a theoretical lawsuit.
Right.
But certain facilities have taken some extra precautionary measures so that if you have a pacemaker or a defibrillator that is MRI compatible, they'll have someone there on site to check the status of it before and after, and to make sure that nothing goes wrong during the MRI scan. So there are some ways around it, but because of the extra efforts you have to go to, it's more difficult to get a quick MRI if you have something that is borderline MRI compatible. So yeah, interesting thing about MRIs.
But I've been more curious than needing it. But I was told that the wire, when I went from a single lead to a biventricular valve or a biventricular pacemaker, which is stimulating both sides of the heart.
Mhm.
In fact, my injection fraction has gone from 33 to about 45.
Wow.
And it's given me a lot more strength, a lot more endurance, because that blood is being pumped a little harder.
Mhm.
And I was told that when I had the biventricular valve, they put in MRI compatible wires.
Mhm.
So when I get the new pacemaker, I think that will be MRI compatible also.
Yep. And then so
Probably
we
at a
take some of
pinch, if I
those.
really had to do that, at least I'm not going to be told, well, no, we can't do that at all anywhere.
Right. And an MRI, so a lot of people say, well, I can't have an MRI scanner. Maybe their pacemaker is just not MRI compatible, or maybe they just have too much claustrophobia and we can't work around it. And they say, well, I can't have an MRI scanner. Well, there's certain conditions a CAT scan will work for, certain conditions a type of injection with a CAT scan, like a type of dye that's injected into the joint with a CAT scan would be helpful for. Or sometimes we just know that a CAT scan's not going to help you at all with what we're looking for. We need to do an ultrasound or just an X-ray, or the only thing that could be done is surgically going in there.
Yeah, right.
So it's not as easy as it sounds. And some people think, well, a CAT scan is better than nothing, but CAT scans don't show you tendons and ligaments very well at all. And so in orthopedics, we don't use CAT scans as much. When we primarily use CAT scans in orthopedics is for bone issues. Maybe there's a fracture that we need to see much better than the detail an X-ray gives us. So we'll get a CAT scan in order to guide management.
Like a vertebrae.
Yep. To really look at the vertebrae. Is there shifting of those bones that's unacceptable? Is a fracture line, is it separated more than a few millimeters? And that's going to create a big problem with arthritis down the line? Or is that fracture more likely to move once we see all the true characteristics of the fracture? X-ray, it's a great screening test, and sometimes it gives us the complete diagnosis. But X-ray, there's a lot of overlapping structures, and so sometimes you can't make enough of the diagnosis and give enough of a proper plan based on X-ray alone. But we were able to do quite a bit before CAT scans and MRIs. We did very well with medicine and
an expert
orthopedics.
to read
And so you don't
X-ray.
always need, So you don't always need these fancy diagnostic scans in order to get relief for your pain.
That's another thing we need to have people understand out there.
Yeah.
There is a difference.
Yeah, and a lot of people, they don't trust as much the doctor's diagnosis. They think the doctor's diagnosis is not as good as an MRI scan, and that couldn't be further from the truth. Sometimes we need the MRI, sometimes we need a CAT scan, other times we don't. So we don't always need every test in the world in order to help you decide what's going on and how you go forward.
Well, the reason I've had Dr. Wisbecki here, and he's going to be a regular on our scheme of things for the year.
What are we planning for? First Thursday of every month, you can find me
right
on this great show.
And the thing is, we have so many seniors in this area with the kinds of difficulties you're talking about. And I think it's important for us to do an in-depth analysis and let people know out there.
Yep. And so, we were talking before about exercise and how you handle some of these wear and tear problems that your body gets from putting all the fun or having all the fun with your body. Heart's getting weaker, muscles getting weaker, balance getting worse, more joint achiness. And so, like we were mentioning before, if there's one thing that's particularly bothering you, maybe it's your left knee, or maybe it's just you feel out of breath, well, then yes, you need to have that addressed. But a lot of the times what I end up seeing is after it's addressed that we're trying to figure out how to keep someone functional and have a high quality of life. And there's various ways to do that, assuming there's no silent heart attack going on or severe asthma that's holding you back. Now, assuming there's not a particular joint that, needs a cortisone injection or whatever, a lot of the times what we're talking about is modifying our activities and how to exercise and challenge your body appropriately. So What were we talking about before with the exercise? There was a topic I think you wanted to hit on with was it how to exercise?
Yeah,
Or
the danger points of exercise. By the way,
yes, some common pitfalls. That's what we wanted to talk about.
through the Florida Orthopedic Group, they also have a physical therapy
unit
component, right?
Yep. So people think there's a lot of common misconceptions with how you exercise. And the first thing is when you have a diagnosis, maybe it's knee arthritis, maybe it's a back issue that's affecting your nerves, you need to know how to exercise properly so that you're not going to get yourself into more trouble, but that you're going to get yourself out of trouble and push things in the right direction. And that's why sometimes physical therapy is key. Yeah, everyone knows how to exercise, but if you don't know how to do it right, in the proper motion, the right kind of exercise, and apply the right mindset, then you're going to get yourself into trouble. And the last thing we want is people falling and breaking their hip or cracking their skull. We want to improve things. So that's part why I recommend physical therapy a lot of the time. It's educational, it's hands-on, and it teaches you common things to avoid and how to do things better. Like, for example, with knee arthritis, people will come and ask me, well, how do I avoid flaring up my knee arthritis? And we know from years and years of study and talking to patients that there's some common triggers. People who are doing too much inclines and declines, like going up and down like stairs or bridges, those inclines and declines, those are going to be really tough on your knee and are more likely to flare things up. So take those out of your exercise program. You don't need to walk the bridge. Okay, you walk the flat surface instead.
Right.
Another thing is unstable surfaces are really tough on the knees. So walking the beach. Some people love to walk the beach. Well, great. But if you're walking in that unstable sand, you're more likely to irritate the knee. And if you still just want to walk the beach, well, then you stick to the harder sand where you're going to get a little bit more stability, or you wear a pair of like beach shoes to get you more stability. Another thing is you avoid trails. You avoid deep knee bends. A lot of younger people will think, I got to do a lot of squats in order to help my knees out. But if you're bending the knee too deep, you're putting way too much force through it. One of the common exercises people do at the gym is with that leg extension machine, kind of where there's that pole that comes kind of across your ankle, and then you bend your knee and then you push that bar back up. And this is a common mistake that I see in every single gym, is that people bend their knees all the way back with that bar and then they extend their knees out. And that is terrible for your knees. You just want to go through a small range of motion from the knee being fully extended to the knee being bent a little bit and stay in that range of motion. So these are some common tips. And I know it's not the best to explain it over the radio, but there are common things that we can tell you that you may be doing wrong, which would massively affect how inflamed the joint gets. Now, activity modifications is something I talk about a lot with my patients. And one personality type that I tend to see a bit more of in orthopedics is those people who still think that they are 20 years old, that they can lift a refrigerator or that they can go and walk 10 miles at Disney out of nowhere, when they are not doing much of that activity anymore, or their body's not ready for that. And so mentally, a lot of us need to come to grips with just what we can and can't do and pace ourselves. If you got to move everything in your house and it's only going to be you and there's no other option, well, it doesn't mean do it all in one day like you did when you were 20 years old. It means small things. Pace yourself, pace your activities throughout the day over the course of weeks, months. And I know it's not fun, and these personalities that we have, we get in our own way, and we're our biggest enemies sometimes. But it's a big part of you staying out of pain, and you just got to be honest with yourself. Because if you're not, then unfortunately you're going to need my help a bit more. And heck, I'm here for you, but I'd hope for you to not need me as much.
True. Yeah. Again, we need to know these kinds of limitations. Or, everything is an adventure. Exercise is an adventure.
Challenging yourself. We got to push ourselves.
It's an adventure.
If you don't use it, you lose
and
it.
Look at it as an adventure. Sometimes even negative things are adventures, to figure out how to make them positive. I mean, I'm always this half full glass guy.
Yep.
And a lot of people I deal with are half empty people. And I don't disdain them, but I try to encourage them. Hey, it's okay. You woke up this morning, here you have another day. You live every day as if it's the last day of your life, because one day you're going to be right. Yep. It's going to come to an end. We know that. And the death process started at birth.
Yep.
George Bernard Shaw, and you can't live. I don't think it's wise to live that way. Just take advantage of what you're doing. Try to accomplish whatever you can and go to sleep. If you wake up the next day, start all over again. And again, if you have limitations, learn to deal with them, learn to work around them, or learn to somehow make them easier and better.
Yeah. Yeah.
And a lot of it is finding the right physicians who will help me on that path.
Mm-hmm. You know, another common thing as we talk about this, this aging process is a lot of people don't want to appear old. I don't like that term old. I like the term wear and tear quite a bit. We get wear and tear on our hearts, wear and tear on our kidneys, on our joints, on our skin, our veins. I like that wear and tear. And so people don't want to appear older. They don't want to be seen limping or seen with a cane or a walker because, they tell me they don't want to appear old. And this is something I'm constantly struggling with my patients on, because if you're limping from a bad knee, and number one, you don't look so young if you're limping with a bad knee. And do you really look that much older by using a cane? I don't think so. And by short-term using the cane or a walking device, that's going to allow you to not be limping and looking older anymore. But then also it's going to help you to walk smoother, and you'll get out of that. I see so many people who for months have been limping, and then the treatment, the success, the healing time takes so much longer because they've been putting off the problem for so long. So being more aggressive on the early side and really listening what your body tells you, you're going to bounce back that much quicker and stronger.
And if you're going to buy equipment, buy the right equipment.
Mm-hmm.
If you're going to get a walker, I saw the new walker, which is an upright standing walker.
Yep. Get the one that's appropriate for
Not
you.
the one that's bent over looking
your
at the ground.
neighbor's walker
that you
maybe
can walk straight out, more erect when you're walking.
Your neighbor's walker or cane may be convenient for you, but it may not be the best long-term solution.
Exactly.
Bring it in with you when you go to the doctor's office. If you're going to come in and see the doctor for a knee problem or a hip problem, whatever, bring in that cane or that walker that you've been using, bring in the brace that you've been using, and then we can give you tips on that right then and there.
Exactly.
Yep.
Exactly.
So yeah, you're right. Finding the right doctor. I like to think that I'm one of the right doctors for a lot of people.
Oh, we'll see. We'll see. So far, you're measuring up.
Yep. And so again, if someone wants to come and see me in the office, my telephone number is 335-4770, Florida Orthopedic Specialist, or you can find me at drw.org.
drw.org. I like that.
Yeah.
Not the whole name, just the W.
Yeah, a lot of my patients, they have a tough time with my last name, and so I get a lot of Dr. W. That's completely fine.
Hey,
yeah,
it's better than hey you.
Hey,
my first job for pay, regular job, was at that railroad factory, and after 2 weeks, we went up to get paid, and there was a cage. You went and got in line and got up to the cage thing and gave your whatever, and I went up. And the lady looked at me and said, "I'm Pat Sacco." She said, "I don't care what your name is. What's your number?" So I gave her my number, and I walked by and said to myself, someday I'm going to be a name. I'm not going to be a number all my life.
Well, so next for next time, if people want to shoot you emails or calls, and if they want me to answer questions over the air, I'd be happy to. Yep, we have another program through the radio station called Bone Talk, where we do every Wednesday morning at 10 o'clock that we take on-air questions too. And I think you take on-air questions
That's
here also,
WPSL.
Right? Yep.
And the other, we take questions. Evan 220-9788.
Yep. So,
write that number down, because when Dr. W comes back, you can call in and ask those questions.
Yeah.
We have 30 seconds. Thank you so much for being here today. Look forward to a happy time with us. And we'll see you again next week on the Forum.